Welcome to the quick revision series of internal medicine. This is helpful for medical group. Whoever is applying for medical group in the 2021 NEET super specialty. In this, I'll be trying to complete entire internal medicine Harrison's 20th edition in 45 days. I'll be covering all the important topics from the part 1 to part 20. And in this, we shall be discussing important tables, important changes, differences that you might miss out in your regular MCQs. My recommendation is I'll give you a timetable for next 45 days. In this timetable, you read the chapter whole day, and on the same day in the night from 9 p.m. to 11 p.m. every day for 45 days, I'll take a class on that particular chapter. All right, in the morning what you will have to do, you will have to do a lot of MCQs. In the night you attend my class and go to sleep. During my class, if you have any doubts, you ask in the next class. During my class, definitely you will miss few points which will be covered in my class, right? In the morning what you have read, in the afternoon what you have read, those points will be missed. So my class will be aiming, it's a master class, I will be aiming to cover those points. So the timetable will be published shortly. This is a sample class, right? We'll be discussing fever of unknown origin. Very, very important class. Straight to the points we'll discuss. We'll discuss important scenarios. Please remember, NEET super specialty medical group. It will be 50% of the paper, according to me, will be scenarios, clinical scenarios. All right, because they'll have to cover whole topic, whole subspecialties, different components, different chapters they'll have to cover. So for that, what is the easiest method for exam is to put up a clinical scenario. We have seen last year NEET 2020 was very, very tough exam. Seeing that, the toughness level will be almost equally same. So what will be the question in fever of unknown origin? Fever of unknown origin will not be asked you as a fever of unknown origin. He'll be mentioning that a 30-year-old male presenting to you with fever for the febrile illness for more than 3 weeks. Febrile illness for more than 3 weeks. All right, for more than 3 weeks. Yes. And the fever is more than 101 degrees Fahrenheit. The fever is more than 38.3 degrees in Celsius. This point on two separate occasions. And despite 1 week of patient's inpatient evaluation, got admitted to our hospital at least for 1 week. Despite that, the diagnosis is uncertain. So this patient is going to come. What they'll ask you, what are the workup done? What should be the workup done? They'll ask you important points regarding the specific list of investigations. They'll ask you fever of unknown origin is defined as which of the following is not a criteria for fever of unknown. All except question is going to come. So in this all except question is going to come. They'll be asking you what will be the fever level. They'll ask you in the one options. Then they'll ask you duration. Then they'll ask you whether patient is immunocompromised or not. A known case of immunocompromised state will be excluded from fever of unknown origin. Please remember this point. Diagnosis that remains uncertain throughout history taking, physical examination. It is not investigation alone. You start from your basics. History taking, physical examination, obligatory investigations like ESR, CRP was done. ESR and CRP was done. Platelet count, leukocyte count. If you're able to follow. Yeah. Leukocyte count. Then the differential. Then the measurement of hemoglobin, which is very, very important. Measurement of electrolytes, creatinine. Then LFT, total protein, alkaline phosphatase, alanine transaminase or aminotransferase, aspartate transaminase or aminotransferase, lactate dehydrogenase, very, very important. Don't miss it, because if it is elevated, then your diagnosis will be any hemolytic picture. Alright, it could be infectious hemolytic picture, or it could be oncology, that is Hodgkin's lymphoma or autoimmune conditions. We'll discuss that in differential diagnosis. Then creatine kinase, then ferritin, anti-nuclear antibodies which rule out the connective tissue disorders, rheumatoid factor, which is one of the important causes of prolonged fever, but not pyrexia of unknown origin. Then protein electrophoresis. These are the investigations. He'll ask you all except question. This is what you'll have to remember. Then electrophoresis, then urine analysis should be done. 3 times blood culture should be drawn. You know that, be prior to antibiotic. What are the important conditions to draw blood culture in a fever case? This should be done prior to antibiotic. Each culture should be at least 1 day, 24 hours apart. The first 2 cultures can be taken and drawn from the same day, but the third culture should be at least 24 hours apart. Strict aseptic precautions should be followed, right? All these points, and a list of antibiotics which was previously used should be handed over to the microbiologist. These are the important points you need to mention, you need to remember for any blood culture that you want. Then urine culture, similarly we've got chest x-ray, ultrasound, tuberculin skin test, IgRA, and nowadays COVID, that is RT-PCR. All these tests should be done, and diagnosis has remained uncertain. Please remember, after doing all this also, the diagnosis has remained uncertain. All right, this is Harrison's 20th edition we are following. Then they'll ask you about one table which is very, very important, the 17.1 table. This, which summarizes the pyrexia of unknown origin. What are the different studies done? You will have to remember a few studies. Please remember the latest ones. The Vander Square and et al. This study you'll have to remember. They have mentioned that infections were 17% and non-infectious conditions are more common. So they'll ask you according to this. And then of course unknown cases are also high, but in known cases apart from these 4, so these will be the options: option 1, option 2, option 3, and option 4. He'll ask you infections, which one of the following is the most common cause of fever of unknown origin. So what you'll have to mention is it infectious, is it non-infectious, is it neoplasm, or is it miscellaneous? If you see the last trial, the Robin et al. Trial, also mentioned non-infectious or inflammatory disease. Rheumatological conditions, non-infectious conditions, inflammatory conditions are common for pyrexia of unknown origin overall. Then second most common also they can ask you, second most common was the infection, right? If you see the older studies, in older studies infections were common. Now non-infectious conditions are common. So remember this point. Then we'll go to the next, the latest study that is mentioned in 2014, 2015, 2016. In 2014, 2015, 2016 study, if you can see, again the infectious conditions have gained importance. So if they ask you, the infectious conditions have again rised back, and obviously the pandemic has made it more obvious now with secondary infections coming after COVID. So that also you'll have to remember. But obvious things, common sense things will not work when they ask you trials you have to study separately, but right now you don't have time. So what you do is just this table you follow. All right, in this table just give a look to this table and you will be able to understand. So these are the pyrexia of unknown origin past 25 years. All right, and next let us talk about the differential diagnosis now. The differential diagnosis of this table, I'm expecting one question this year. Very, very important table. Please read this table and go. this table I'm expecting these are all the reported causes of fever of unknown origin, all the reported causes of. So they'll ask you what are the important bacterial cause, what are the important specific bacterial causes, fungal causes, parasitic causes, viral causes. So infectious causes I don't think they will ask you, but non-infectious in this table, this part is very, very important. This part is very, very important. So what you'll have to do is you have to just start reading from this point. The non-infectious inflammatory disease, non-infectious inflammatory diseases, systemic, rheumatic and autoimmune disorders, the vasculitis, the granulomatous diseases, the autoimmune inflammatory syndrome, these 4 categories you will have to remember. They'll ask you which of the following is a cause of pyrexia of unknown origin in non-inflammatory causes, something like that they'll ask you. So these syndromes, the Still disease, Blois syndrome. What is CAPS? CAPS. What is CAPS? What is CAPS? So cryopyrin associated periodic syndrome. Cryopyrin. Remember, in the pathophysiology of fever, in another class I'll teach you what is pathophysiology of fever. In that, please remember the most important interleukin nowadays that we are talking about is cryopyrin. Cryopyrin associated periodic syndromes, then the Crohn's disease, then DIRA, that is deficiency in interleukin 1 receptor antagonist, DIRA syndrome, then HIDS syndrome. So this HIDS, all right, also known as the hyper IgD syndrome. Somebody who has written AIMS, a recent AIMS paper, they'll mention all these syndromes. They'll know how important these syndromes are. The Schnitzler, I'm sorry, it's difficult to pronounce. Then TRAPS, that is tumor necrosis factor associated periodic fever. All these categories are coming under autoinflammatory syndromes. Which of the following is autoinflammatory syndrome associated with pyrexia of unknown origin? This question is going to come, or they'll ask you to expand PFA-PA syndrome, FAPA syndrome, PFA-PA syndrome, that is FAPA syndrome, periodic fever after ulcers, stomatitis, pharyngitis, adenitis, then recurrent idiopathic pericarditis, then SAPHO. What is SAPHO syndrome? Many times the PGI has asked this question. Many times this question came in PGI exam. Synovitis, acne, pustulosis, hyperostosis, and osteomyelitis. So synovitis, acne, pustulosis, hyperostosis, and osteomyelitis. We all know the granulomatous diseases which cause. In this, the new addition is idiopathic granulomatous hepatitis. Idiopathic granulomatous hepatitis. Idiopathic granulomatous hepatitis. It's a very, very important factor. Then, what are the important neoplasms associated with periodic neoplasms associated with fever of unknown origin? What are the important neoplasms associated with fever of unknown origin? Separately, you know that there is a division of hematologic malignancies. Then this is one. Then the solid tumors. Then the benign tumors. Benign tumors associated with pyrexia of unknown origin, cavernous hemangioma of the liver. Please remember this point. Common and common to be associated, and they'll ask you which of the following is not a cause of benign tumor causing pyrexia of unknown origin, like that. All except questions might be coming. Most of the solid tumors and metastasis can cause fever, so you'll have to differentiate, is it metastasis causing fever or solid tumor causing fever. Pyrexia of unknown origin associated with solid tumors like breast. See, most common they have mentioned inheritance, and definitely this question is going to come. Hepatocellular cancers, in order they have mentioned lung cancer and pancreatic renal cell cancer, pancreatic cancer and renal cell cancer. All right. Then what are the important hematologic malignancies associated with pyrexia of unknown origin? Castleman's disease. Many times this question came in AIMS exam. Castleman's disease, Hodgkin's disease, everybody knows that they'll not ask you. Then hypereosinophilic syndrome. This question also, hypereosinophilia, I'll separately teach in rheumatology. Very, very important. Definite one questions will come from hypereosinophilic syndrome in rheumatology, right? Then multiple myeloma. We all know multiple myeloma is important cause of pyrexia of unknown origin. You will have to, these are differential. Then plasmacytomas, systemic mastocytosis. This question came in 2020 NEET exam. You'll have to remember from this, a question was there, right? Then the other causes. there could be a thermoregulatory disorder wherein person will be coming and telling the doctor, I have very less sweat and hydrotic ectodermal dysplasia. Then exercise induced hyperthermia, hyperthyroidism, endocrine cause of fever, they'll ask you, hyperthyroidism, pheochromocytoma. All right, remember these points. Then what are the central causes? Brain tumors, cerebrovascular accident. Will cerebrovascular accident cause fever? Yes. Is it a good prognosis or a bad prognosis? It's a very, very poor prognosis. Please remember, two important poor prognosis in stroke or CVA. One is fever, another is, yes, you have guessed it right, it is hyperglycemia. Two important two important poor prognosis at the time of presentation, fever and hyperglycemia. Please remember, these are the bad prognostic indicators at the time of presentation of a stroke. Remember this part. Then encephalitis, we all know that encephalitis may be associated with fever, they'll not ask you. Hypothalamic dysfunction also, it is very easy to guess. Now please make a note of these syndromes. The Mollaret syndrome, that is aseptic meningitis. Mollaret syndrome, if you are able to follow Mollaret syndrome, neutropenia, the two important diseases which AIIMS commonly asks and can be expected in NEET. I'll just show you. Is it visible? Is the font okay? Yes. Kikuchi disease. Have you heard Kikuchi disease? Then the subacute thyroiditis. Then TINO, that is tubular interstitial nephritis, which is diagnosed by the tubular cast, protein casts, and uveitis syndrome, TINO syndrome. Then gastroenterology causes like ulcerative colitis. So all these are important causes. All these are important. System wise, you'll have to remember all cardiac causes are there, neurology causes are there in this table. Please remember, these are the miscellaneous causes of pyrexia of unknown origin. All right. So next we'll discuss this table. Patient without a known immunocompromised state, patient with more than 101 degrees Fahrenheit and more than 3 weeks. Please remember, you will have to take history and physical examination. This is the first step. Then after that, you will have to go for this, because you are going to collect the blood culture. Especially, I told you, you have to stop antibiotic treatment, glucocorticoids, and then you exclude any manipulation of thermometer. Many a times electronic thermometers, people are buying thermometers of cheap quality, and it will be manipulation of thermometer. Practically, if you are a practicing physician, you will definitely come up with these things. Then you will have to, this patient has to perform the important diagnostic procedures, and if the important diagnostic clues are present, then you go for guided diagnostic test. If it is absent, then you go for slightly rare diagnostic tests like cryoglobin, serum cryoglobin levels, and fundoscopy. We can miss this also. Practically, you can directly go for PET CT. They'll ask you, PET CT is indicated when the potential diagnostic clue, PDC means potential diagnostic clues, are misleading or absent. This point will be coming as a question for you. If it is absent, then you go for indication is PET CT, right? If the PET CT is abnormal, then you come to a diagnosis. If diagnosis is not bad, and also if the PET CT is normal, then what you'll have to do is you will have to perform a potentially diagnostic clue driven invasive testing. So when is the invasive testing advised? When PET is either normal or inconclusive, diagnosis is inconclusive, then you go for the invasive testing. This is the next question from this table. Next question after this. So this is the second question from this table, right? Then first question I told you, indication of PET. Second question I'm telling you, indication of invasive testing in pyrexia of unknown origin. Then if there is no conclusive diagnosis, then you go for CT temporal artery biopsy. CT temporal artery biopsy to rule out what? Giant cell arteritis. All right. Temporal artery biopsy to rule out giant cell arteritis. Abdominal CT or chest CT to rule out lymphomas or any solid tumor malignancy which can also be ruled out in initial stages with the PET, but sometimes few lymphomas may not pick it up, rare causes of lymphomas which will not pick it up. And thus diagnosis, if diagnosis is made, okay. If diagnosis is not made, patient's condition is stable, then consider NSAID treatment. If there is deterioration, which most of the times happens, then you go for a therapeutic trial, some trial therapy, you can go for it. So trial therapy is advised if all these things are negative. So this is what you should understand in patients management protocol, right? How will you treat? Antibiotics, anti-tubercular therapy. Antibiotics, anti-tubercular therapy. This is very, very common. If the tuberculin screen test in India, it is very, very common. So we are habituated to it, and definitely a question from anti-TB drugs, definitely a question is going to be expected in NEET 2021 super specialty exam. Then what are the important drugs which are indicated in pyrexia of unknown origin? First is colchicine, second is the NSAIDs, third is the steroids, third is the glucocorticoids. So next is anakinra. What is anakinra? Anakinra, we all know that it is IL-1 mediated receptor antagonist. IL-1 receptor antagonist, right? IL-1 receptor antagonist. So we have got, it has got activity on all is true about anakinra, except such question is going to come from this paragraph. Please read this paragraph. I was talking about one syndrome, which is the tongue twister for me, Schnitzler syndrome, Schnitzler syndrome, then hyper IgD. I have shown you one paragraph, is it not, of different potential causes of what do you say, pyrexia of unknown origin. In that, when to use anakinra. Anakinra is extremely effective treatment for many autoinflammatory syndromes. So autoinflammatory fevers like familial Mediterranean fever, then CAPS, the CAPS syndrome, that is the cryopyrin associated syndrome, then the tumor necrosis factor associated periodic syndrome, mevalonate kinase hyper IgD syndrome. I already discussed these syndromes. All right, so these are all the inflammatory causes which are almost all chronic inflammatory conditions without a known basis are controlled by glucocorticoids, is it not? Then monotherapy with IL-1 blockade can provide improved control. Remember this point, right? So this completes the topic of pyrexia of unknown origin. Thank you.